Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's continue our physiology playlist. In previous videos, we talked about many aspects of GI physiology. Today, we will dig deeper. It's a video about miscellaneous topics. We'll start by talking about gastrointestinal reflexes, and then we'll have a garden variety of diseases, and how your understanding of gastrointestinal physiology can help you master gastrointestinal pathology. Let's get started. If you want a video like this, I have a clinically oriented musculoskeletal physiology in this physiology playlist. Gastrointestinal reflexes. Recall that there are two types of control in your gastrointestinal system: the nervous control and hormonal control. Of course, this is example of nervous control. Let's go. Gastroenteric. When the stomach is talking to the intestine. Gastro, stomach. Enteric, intestine. Which means the presence of food in your stomach will distend your stomach. And then when the stomach distends, we will send signals to your intestine, telling your intestine, you know what, it's time to empty yourself to get ready for the new meal. Next, gastrocolic, from the stomach to the colon. Distension of your stomach by food will tell the colon to evacuate to get ready for the new meal. Duodenocolic reflex, from the duodenum to the colon. Distension of the duodenum by the presence of food will tell the colon to evacuate to get ready for the new meal. Gastroileal, from stomach to ileum, which is the last part of the small intestine. Distension of the stomach will increase ileal peristalsis to increase ileal emptying into the colon by means of the ileocecal valve, which means we need to relax the ileocecal sphincter. Next, enterogastric, from the intestine to the stomach. As you know, the intestine and the stomach hate each other. The intestine hates the stomach with vengeance because the intestine needs an alkaline medium, but the stomach keeps throwing acid on the duodenum. So distension of the intestine, whether it's large intestine or small intestine, will tell the stomach to shut up, shut down, and decrease gastric motility, decrease gastric emptying, decrease gastric secretion. This hate-hate relationship is not just nervous, it's also hormonal. Remember that gastrin is the hormone that is pro-stomach. On the other hand, cholecystokinin, secretin, VIP, GIP, all of them are intestinal hormones that hate the stomach. Next, colonoileal, from the colon to the terminal ileum. Distension of the colon with food will tell the ileum, hey, calm your butt down. No pun intended. I have enough food in me already. Just chill, by reducing emptying of the ileum to the colon. Moreover, when we have too many particles in the colon, this will increase colonic pressure, which closes the ileocecal valve, which reduces the emptying of the terminal ileum into the cecum. Now pay attention, because the last three reflexes are extremely clinically relevant. Let's go. Peritoneal intestinal reflex, from the peritoneum to the intestine, which means irritation of the peritoneum, such as peritonitis, which could be primary peritonitis or secondary peritonitis, can cause inhibition of intestinal motility, paralyzing your gut. It can lead to a scenario very similar to paralytic ileus with obstipation and constipation. So you mean that peritonitis can lead to constipation? Yes, indeed. Next, renointestinal. Kidney irritation will inhibit the intestine. What irritates the kidney? It could be a stone in the renal pelvis or in the ureter, for example. This will inhibit intestinal motility. When was the last time you saw a doctor asking a patient about history of kidney stones because the patient came today complaining of constipation? See, here is the problem. Most doctors are doofuses and they have no idea what the flip they're talking about. Please do not be a doofus with a stethoscope. Last, vesicointestinal reflex. Irritation of the vesicle. What's the vesicle? Urinary bladder. Do you remember the vesico-ureteral reflex? Stones in the bladder or irritation in the bladder can lead to inhibition of intestinal motility. Can you name a parasite that will do this? The answer is Schistosoma hematobium.
Oh, so you mean that schistosoma hematobium, even while having its eggs irritating my urinary bladder, can lead to constipation?
Yes, it can. These are the reflexes for today. If you want to learn about the mastication reflex, deglutition reflex, and defecation reflex, check the previous videos in this physiology playlist. And if this was not clinically relevant enough, let's take it to the next level. We'll try to go from head to toe, from oral to anal, from cranial to caudal, from gum to bum. Number 1, deglutition. We talked about the swallowing reflex before. Where was the swallowing center? In the medulla, because the medulla has 4 important centers: heart and lungs. Get it in, get it out. What are the cranial nerves responsible for swallowing? Many, including 9, 10, 11, and don't forget 5. For the tensor palati muscle, to elevate that soft palate and protect the nasal cavity while swallowing. Now let's try to enumerate some causes of dysphagia, which means difficulty swallowing. Do you remember phagocytosis?
Oh, it's when the macrophage swallowed the bacteria.
Good job. Phagia is swallowing. Dys means difficulty, as in the word dysfunction. Causes of dysphagia could include a problem in the center.
What do you mean?
Your medulla. Oh, like poliomyelitis, like encephalitis affecting the brainstem? Sure. Problems in the nerves, such as cranial nerves 5, 9, 10, etc. Or it could be a problem in the enteric nervous system in the esophagus, particularly the myenteric plexus. Remember when we said before that the myenteric is for motility. If there is dysfunction of the myenteric, there will be no motility, especially no relaxation. Absence of receptive relaxation will make the esophagus unable to relax, unable to accept and receive the food, and therefore unable to give it to the stomach. So food will pile up in the esophagus until the esophagus enlarges like mad. Mega esophagus, giving you this classic bird beak appearance. Accumulation of food in this area will raise the esophageal pressure. If this is too much, your esophagus can rupture, called Borav syndrome, which is a stinking medical emergency.
Okay, medicoses, before all of this happened, how can I treat this?
Well, if this is so narrow and cannot relax, you can insert a balloon to dilate it. Antispasmodics might provide some relief. What is esophageal rupture? It is Borav syndrome. All of the esophagus is involved, usually after forceful retching, forceful vomiting, which increases pressure, or after severe chronic achalasia, which is failure of relaxation of the esophagus, which raises the pressure. And then, boom, after the esophagus ruptures, what's going to happen? Everything that was in the esophagus will go to the outside. Oops, air and fluid in the pleura, in the mediastinum, causing pleurisy and pleural effusion. Mediastinitis, which can be fatal. In the hospital, my patient is complaining of forceful continuous retching and vomiting just before the rupture. Feel the patient's chest, you'll hear air bubbles cracking under your fingertips.
What's that air?
It's the air that leaked out of the esophagus. Oops, we call this subcutaneous emphysema.
Is this the same as the emphysema in the lung?
No, it's not the same. This can kill you. Of course, I can expect fever and leukocytosis. White blood cells are trying to clean up the mess. This can lead to dyspnea, which is shortness of breath, and septic shock. Risk factors include the following: forceful retching and vomiting, such as chronic alcoholism, trauma, especially if my doctor was a doofus and ruptured my esophagus while inserting an endoscope into my esophagus. How can I confirm the diagnosis? Use upper GI endoscopy, but do not use the ordinary contrast. Instead, use water-soluble contrast.
What's wrong with the non-water-soluble contrast?
The non-water-soluble contrast is very toxic. Do you want a toxic substance to leave the esophagus and go to the pleura and mediastinum?
Heck no!
Therefore, use something water-soluble so that if it leaked, because the patient has ruptured esophagus, It is not the end of the world. And here is something beautiful, not for the patient, of course. Pleural effusion, I hear you. Exudate, of course, because it's inflammation with increased amylase inside the pleural fluid. Where did the amylase come from? This is the salivary amylase, which came with the saliva from the mouth into the esophagus, and then the esophagus ruptured, so the esophageal fluid with the amylase in it will leave the esophagus and will go to the pleura. And for the first time, you have a ton of amylase in the pleural cavity. This is classic Burav syndrome. And of course, if the patient is about to die, it's time to go to surgery right now. Neuroanatomy and neurophysiology of the tongue. Anterior 2/3 versus posterior 1/3.
Why do I care?
Because embryologically speaking, the tongue had two different origins, with the foramen cecum in between and the sulcus terminalis. Your thyroid gland originated here. Back to neuro. Anterior 2/3 of the tongue are supplied by the chorda tympani branch of the facial nerve if we're talking about taste sensation. The anterior 2/3 of your tongue is supplied by the lingual branch of the mandibular nerve if we're talking about general sensation, not taste, but pain and touch sensation to the anterior 2/3 of the tongue.
How about the posterior 1/3?
Glossopharyngeal.
Taste or pain and touch?
All of them. Everything. So far we have 3 nerves that supply the tongue. You want a 4th one? Cranial nerve 10, vagus, the most posterior part of the tongue, the tip of the palate, the tip of the epiglottis, and the back of the pharynx. This could be of tremendous importance to a physician trying to diagnose a cranial nerve palsy. Remember that the saliva is very important. It cleanses your mouth because of lysozymes and IgA. It digests carbohydrates, it buffers the acid, it has many functions. Be careful because many medications cause dry mouth, xerostomia. Lack of salivary secretion will lead to absence of the buffer against the acid, absence of lysozymes and IgA. The bacteria in your mouth may win. These bacteria secrete acid, and you do not have a base to buffer it because you do not have saliva, and you will start to suffer from tooth decay. This is probably one of the reasons tooth decay is very common in the modern era. There is another disease that causes xerostomia. Sjogren syndrome. It's a triad of dry eyes, dry mouth, and arthritis. Can this lead to tooth decay? Yes. Next, the stomach. Peptic ulcer disease is an imbalance between the pro-acid factor and the anti-acid factors. Example, too much acid, too little mucus. What are you trying to achieve as a physician? Decrease the stomach acid using one of these medications and increase the mucus and increase the protection of the stomach, such as one of these medications. The imbalance between the acid and the anti-acid can damage your esophagus. This is called gastrointestinal reflux disease, the classic heartburn, reflux esophagitis, or peptic ulcer disease, which could be an ulcer in the stomach or ulcer in the duodenum. The word peptic should remind you of pepsin, which came from the peptic or chief cell in the stomach. All of the medications used to manage peptic ulcer disease are discussed in my Utecoids pharmacology course, which you can download at medicosisperfectionalis.com.
Hey Medicosis, can I use atropine to manage peptic ulcer disease?
Let's think about that. What is atropine?
It's a muscarinic receptor antagonist.
And the muscarinic receptor is for whom?
For acetylcholine.
That is true. So in that sense, atropine is beneficial. However, pay attention. Acetylcholine is not the only game in town when it comes to acid secretion. The most important factor is GRP, also by your vagus, gastrin-releasing peptide. This is the hero of gastrin release. So even if you give atropine to block the acetylcholine, Mr. Vagus will still release gastrin-releasing peptide, which will boost gas secretion, which will boost acid secretion.
Do we have a better option?
Unfortunately, yes. It's a brutal option. Cut the vagus that goes to the stomach. And when you cut the vagus nerve, you will lose the acetylcholine fibers. You will also lose the GRP fibers. What is the name of the vagus nerve when it comes near the stomach? Anterior and posterior gastric nerves.
What if chronic severe peptic ulcer disease is not managed?
Well, the ulcer will just keep eroding and eroding and eroding and eroding through the wall of the stomach until perforation and internal bleeding, which can be fatal. Remember the difference between erosion and ulcer. Erosion is the removal of the epithelium. Ulcer is the removal of the epithelium and the basement membrane, which means ulcers are worse than erosions. Remember that ghrelin wants you obese by boosting your appetite. Ghrelin, gluttony. So this GI hormone is one of the 7 deadly sins. High testosterone and low thyroid hormone are 2 other deadly sins. No one will get the joke. Remember that normally your parietal cells should secrete HCl or hydrochloric acid, which will activate pepsinogen into pepsin. What if I do not have hydrochloric acid? Well, you have achlorhydria. No hydrochloric acid, which means the pH of the stomach will never go below 6.5, even after maximal gastric stimulation.
Is this a good thing or a bad thing?
It's a horrible thing, because without the acid, you cannot cleanse your stomach and you cannot activate pepsinogen into pepsin, which means you probably cannot digest proteins properly. Recall that pepsin was extremely important in digesting collagen. What is peristalsis? Peristalsis is the peristaltic movement. We push the food from point A to point B. In which direction? Oral to anal, cranial to caudal, proximal to distal, from gum towards the bum. Conversely, anti-peristalsis is moving in the opposite direction. Hashtag vomiting. Speaking of vomiting, it causes hypochloremic, hypokalemic metabolic alkalosis. Why hypochloremic? Because you're losing the chloride with the vomiting, which came from the stomach, by the way. Why metabolic alkalosis? Because you're losing the acid, you're losing the H. When you lose the acid, you become alkalotic. When you lose the riches, you become poor. And also you lose some potassium, so you get hypokalemia. Moreover, when you vomit, you lose volume. When you lose volume, you get volume depletion. And when you get volume depletion, aldosterone goes up. When aldosterone goes up, potassium in the blood goes down. So in a nutshell, vomiting causes hypochloremic, hypokalemic metabolic alkalosis. Metabolic alkalosis is evil. Metabolic alkalosis is when your blood pH is higher than usual, caused by something other than the lungs. Why is metabolic alkalosis evil? Let me explain. Remember the oxygen dissociation curve, shift to the right versus shift to the left. Acidosis is here, but alkalosis is there. What does alkalosis do? It shifts the oxygen dissociation curve to the left, which means more binding of oxygen to the hemoglobin and less dissociation, which means less unloading of oxygen from the hemoglobin to the tissue. When your tissue is receiving less oxygen, that is evil. Metabolic alkalosis will cause a left shift, where the tissue is left behind without oxygen. Metabolic alkalosis also precipitates calcium, so the ionized calcium in the blood will go down because it's going to somewhere else to precipitate. And calcium and nerve excitability are always opposites. When calcium is low in the blood, nerve excitability is high. That's why alkalosis can trigger a tetanic contraction. Now that's evil. Acidosis dilates your cerebral blood vessels and boosts your cerebral perfusion. Alkalosis does the exact opposite. It causes cerebral ischemia. All of this is evil. If you want to take it to the next level, download my acid-base imbalance course. Gastrin is natural, pentagastrin is synthetic. Somatostatin is natural, octreotide is synthetic. Remember, this is my doofus, which inhibits everything. It inhibits motility, it inhibits secretion of everything. That's why we can give octreotide to a patient who's secreting too much gastrin, or too much insulin, or too much glucagon, or even too much somatostatin. Vipoma. This is a tumor releasing too much VIP. It can be part of WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. One of the ways to treat vipoma is to give octreotide because it's a somatostatin analog, which means universal inhibitor, which will inhibit the release of VIP. Remember that your duodenum absorbs iron and calcium. Jejunum absorbs folate, terminal ileum absorbs cobalamin and bile salts. Or you can say B and B, B12 and B bile salts. Here is folate being absorbed in the jejunum. Thank you, conjugase, jejunum conjugase. And this is inhibited by phenytoin, alcohol, and oral contraceptive pills. They are not good for your folate level. Here is vitamin B12 absorbed at the terminal ileum thanks to the intrinsic factor which is released by the parietal cells of the stomach. Anytime you have biliary colic and right upper quadrant pain, blame cholecystokinin for contracting your gallbladder too much. What is cholecystitis? Cholecystitis, inflammation of the cholecyst, which is the gallbladder, because there is a stone obstructing my cystic duct. Okay, but what is choledocholithiasis? Well, choledoco is the common bile duct. Lithiasis is a stone. Choledocholithiasis is a stone in the common bile duct. Will gallstones cause jaundice? Well, it depends on where the stone is. If the stone is here, in the cystic duct, the answer is no, because bilirubin can still flow from the liver to the duodenum. No obstruction in this path. However, if I have a choledocholithiasis like this, look at that. Now this is obstructing the path between the liver and the duodenum. Bilirubin will not be able to pass. So this can cause jaundice. So cholecystitis, no jaundice. Choledocholithiasis can cause jaundice. There are two types of gallstones. Cholesterol stones, these are yellow. Bilirubin stones, these are pigmented, usually black. We develop cholesterol stones because we have too much cholesterol and too little bile acid, too little phosphatidylcholine. When lecithin is low, bile acid is low, and cholesterol is high, that's high risk. That's why we say the risk factors for cholesterol stones are fat, fertile, febrile, female, in her 40s with 55 kids. Too much estrogen. Estrogen comes from cholesterol. Too much fat. Who made your plasma proteins? The answer is the liver. And when the liver is toast, i.e. cirrhosis and liver fibrosis, you get liver cell failure. All of this is going to happen. Please pause and review. In order for you to absorb fat and fat-soluble vitamins, 3 organs need to be healthy. Number 1, liver and biliary system. Number 2, the pancreas. Number 3, the gut itself. That's why a disease in the liver, or a disease in the biliary system, or a disease in the pancreas, or a disease in my bowel can lead to malabsorption of fat and fat-soluble vitamins, such as vitamins K, E, D, and A. Vitamin K deficiency will give me bleeding. Vitamin E deficiency will cause anemia, anisocytosis, and nerve problems. Vitamin D deficiency, bone problems. Vitamin A deficiency, vision problems. When you are unable to absorb fat or fat-soluble vitamin, we call this steatorrhea, because you have tons of fat in the stool, and your stool will be described as greasy, oily, foul-smelling, and floats on the surface of water in the toilet bowl. If I have inflammation of the liver, AST and ALT will be high. If I have inflammation of the pancreas, amylase and lipase will be high. Amylase is sensitive but not specific because you also have salivary amylase. Lipase is more specific. Don't forget that VIPoma causes diarrhea. Also, cholera toxin causes diarrhea, and we talked about the mechanism before. It has to do with activating cyclic AMP, opening chloride channel. Chloride is going to enter the lumen of your bowel. Sodium is going to follow electrolytes because of electroneutrality. Water is going to follow salt because of osmosis. And before you know it, you're losing tons of water and some salt in the stool. This volume depletion is deadly. Next, the colon. Failure of migration of the neural crest cells to the colon means that you have problems with your peripheral nervous system. No ganglia and no enteric nervous system. What do you mean by enteric? Myenteric and submucosal. They are gone. That's why part of your colon will be dilated like this, and this is full of stool. If a doctor inserted a gloved finger this way, squirting of stool will happen. This colon is filled with stool, but it cannot contract. It cannot evacuate on its own. The defecation reflex was discussed before. Remember when I told you, in order to decrease your risk of constipation, train yourself not to ignore the natural urge to poop. Ignoring this natural urge time and time again increases your risk of constipation. Doofuses who abuse laxatives chronically will eventually lose their natural urge to defecate, leading to colonic atonia, loss of tone in the muscles of the colon, and chronic constipation. Always listen to your rectum. Where is the center for defecation reflex? It's in the spinal cord. Can we be more specific? In the sacral segment near the conus medullaris. Suppose that I developed a spinal cord injury here. I severed my spinal cord between the conus medullaris and the brain. The question is, will the basic defecation reflex happen? The answer is yes, because the spinal cord here is still functioning and still communicating with my colon. However, there is no connection now between the cortex of the brain and the defecation center, which means I can no longer voluntarily defecate. I cannot volitionally decide to increase my intra-abdominal pressure and expel the stool. Defecation can happen without my volitional knowledge, but it is difficult. That's why many of these patients find daily enemas useful. Do you want to learn about paralytic ileus, small bowel obstruction, Barrett's esophagus, esophageal carcinoma, colon cancer, etc.? Download my surgery high yields course at medicosisperfectionalis.com. If you want more physiology, check out my renal physiology course on the same website. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.